Ozempic is a brand of semaglutide, and it has seen a crazy increase in usage on the NHS for type 2 diabetes over the last couple of years, and I am going to show you this data. It's also seen a massive use in the private sector for weight loss, and recently it now has a new brand called Wegovy that's officially for weight loss on the NHS. I'm Eloise, and I'm a UK pharmacist of 20 years, and I'm passionate about clear, accurate information on medicines and supplements that everyone can understand. This video will be in sections with timestamps below, so you can skip to the correct section. Firstly, I will talk about the background of Ozempic and semaglutide and how it's used in type 2 diabetes, the evidence for it and its side effects. I will then go on to show you the prescribing data with the crazy increase in usage across England, and you can see whether your local area is at the top or the bottom. I will then go on to talk about the new brand of semaglutide called Wegovy and how its use in Tier 3 NHS services has been opened up across the country. But before I start, here are my disclaimers. The information I provide is for educational information only and is my own opinion. However, I do base it on the most up-to-date medical evidence. Always contact a health professional for your individual advice on your own personal situation, whether that be for type 2 diabetes or for weight loss. However, I'm now going to move on to the main topic. Ozempic contains semaglutide, and semaglutide is one of a number of agents known as GLP-1 receptor antagonists. And this as a group based on the incretin hormone that's produced by the intestines after eating. And when the glucose levels are high, it acts on the pancreas to release insulin so as to drop sugar levels down for your body to store the sugar. But if glucose levels are normal, it doesn't cause hypos, which is a problem that we've had with previous medication for diabetes. It also acts to slow gastric emptying and also helps improve the pancreas function and slow any deterioration of the beta cells that are in the pancreas that produce insulin. It also acts on the signals between the stomach and the brain, so making people feel fuller for longer and not having as many sugar cravings, so therefore helping people reduce their calorie input and therefore also in reducing their weight gain or even producing weight loss. There's been quite a few different agents in this class. The first was back in 2005, and it was exenatide, and it came out as a twice-a-day injection. And as it was very new, we didn't have any safety data of the long-term effects. It was only generally used sort of last line for those patients that had really resistant type 2 diabetes. Along came in 2010 liraglutide, which was then a once daily injection, which was a little bit more useful. And eventually, over the years, they managed to make exenatide into a weekly injection and come out with more and more agents that were weekly injections. And then finally, in 2017, the semaglutide came on the market as a newer generation of these GLP-1 receptor antagonists. And since then, their use in the treatment of diabetes has improved. We've got improved data on their actual outcomes, as well as reducing the blood sugar levels in diabetes, actually helping people with type 2 diabetes lower their risk of the complications of the type 2 diabetes, especially cardiovascular events such as heart attacks and strokes, and also just reducing the risk of damage to the kidneys, to the eyes, and all the other complications that come with type 2 diabetes. So over the decades, we've now modified our guidance for the treatment of type 2 diabetes to move this in, whereas it's always been that metformin is the first line agent. This is the one that has got decades of evidence. It lowers blood sugar levels. It can't cause hypos. and does help prevent cardiovascular problems long term and has been proven. So this is still first line. We still always encourage everybody to try this. Unfortunately, not everybody can cope with the gastrointestinal side effects of diarrhea with it, but we always say to introduce it as slowly as possible, just 1 tablet a day for a week, check that you're tolerating it, up to 2 tablets a day for a week, check you tolerate it, and extend as appropriate. We used to then also add in drugs such as sulfonylureas, which was glyphosate and glitazones. Unfortunately, these did come with the risk of hypos, and so the use of these has now dropped out of use, although people who are stabilised on them can continue on them unless there is a change in their condition. So more recently, the type 2 diabetes guidelines, which I will link below from the clinical knowledge summaries and from the National Institute of Healthcare for the UK, is now using these newer agents, the gliptins, which are similar to the GLP-1s but taken orally, and the GLP-1s, and another group called the flozins, which will take another complete episode to cover. So this has been the rise of using semaglutide first line after metformin, and hopefully this should reduce the amount of people that need to go on to using insulin, because unfortunately type 2 diabetes, even though it's due to insulin resistance in the body and a lack of insulin itself, although it will then treat the symptoms of the diabetes and prevent the high blood sugar levels, doesn't actually reduce any of the complications of type 2 diabetes, and can actually in itself produce weight gain. So we try to avoid going on to insulin for as long as possible. Just moving down, unfortunately, the GLP-1s, along with all medications, do have some risks, do have some side effects. So the main cautions are for people who have had pancreatitis previously, because it's acting on the pancreas. It can actually cause, very rarely, pancreatitis. So if somebody is at risk of pancreatitis because they've had it before, they do need to take that into consideration. Obviously, renal impairment. Some of the agents, such as the zenatide, and liraglutide, are actually excreted via the kidneys. Therefore, they will need dose adjustments in renal impairment. The same with hepatic impairment for liraglutide. Moving on to the side effects. So, as I've just mentioned, very, very, very rarely is acute pancreatitis. And this is something to watch out for. So if you were to have sudden upper pain and nausea and vomiting, it would be worth getting it checked out straight away. One of the main, more common side effects is the fact that it causes decreased appetite. Yes, that's also its benefit, but it has to be listed as a side effect, and whether you actually appreciate the decrease in appetite or not. It can also provide sometimes an altered taste, also sometimes a certain amount of nausea, especially if you're trying to eat when you've got the decreased appetite on it. And very, very occasionally, it can then lead to actual vomiting. And if this is an issue, then you do need to talk to your healthcare provider about it. Obviously, there's other issues with the fact that it may slow travel down the intestine tract. So it may cause constipation in some people. But on the reverse, some people end up with diarrhea. So sometimes with drugs, anything can happen. Other very rare side effects have been sort of headaches, dizziness, drowsiness. It could be to do with all of the changes to your metabolism as you are getting used to it. So it's always worth taking a note, seeing how you're doing, seeing whether they're improving or not, and discussing with your healthcare provider whether the benefits of taking it are outweighed by the side effects that you are having from it. And very, very occasionally, as with pretty much every medication, there's always the chance that you could be allergic to it, so end up with sort of skin reactions of a rash and problems. So yes, these are absolutely amazing steps forward for the treatment of type 2 diabetes, but as with all medications, they do come with a certain amount of risk, which is why it needs to be a discussion between you and your healthcare provider of whether you're willing to go on these medications, see how you go, and see whether it improves your HbA1c significantly, whether it does help you with your weight loss, and for continued use. There is guidance from NICE on how to monitor these and to check that you are getting the appropriate reductions in HbA1c, or whether you would need to try a different agent. So now I will move on to the data. For this next section, I'm going to talk you through using Openprescribing.net, which is a resource available for the public to use, which actually gathers all the GP prescribing data for England. So this is any prescriptions that are written or electronically written by GPs in England and sent to a local community pharmacy for dispensing. So it doesn't include things that are done via the hospital, as that's a separate system. And in some areas, some certain types of medication is not done actually on prescription, but done by other home care methods. So this is a very, very useful database that anybody can access. So as you can see, the website up here, openprescribing.net. And if you click on the Analyze tab, this is where we're going to use to start with. There are dashboards and trends which I can do future videos on. But to start with, we're just going to look at the GP prescribing data. So we've got these boxes. So we're going to see the prescribing of, and then you can pick different drugs. So you can do it as different sections of the BNF. So say asthma, or contraceptives, or iron, as I've done previously, or you can actually go in and do the actual chemical name of a drug. You can go down to just the brand level, or you can actually go right down to a presentation. So as we'll start with semaglutide. And as you see, there's the top option there for semaglutide as an agent. We could have gone down to Ozempic. Ozempic is the brand. We could have even gone right down to the different pre-filled syringes and done an analysis of that. But we're just going to use the whole of semaglutide, the whole chemical substance of it, no matter which brand is prescribed and which size pen is prescribed. And we can then just press show me the data. And if we scroll down, it will fetch us the data. Default is it'll just fetch the data of the whole of England and separate it out by the sub ICB locations. The ICB are the integrated care boards, and the sub levels, these are usually places. So these are usually aligned with sort of local council areas. So if we click and look at the top one, NHS of Kent and Medway. We've also got North Central London, Hampshire, Southampton, Isle of Wight, Black Country and West Birmingham. And as you can see, these are actually areas of a high amount of population, and that's the reason why they're showing at the top of the graph. Where some of these at the bottom here, NHS Cannock Chase, maybe a very small amount of people in that local authority, and that's why it's showing very low. So they have a function here of versus, and at the moment it's versus nothing, but we can change that to total list size and then run the data again. Now, this time when we're running the data, it's taking into account the size of the population in the area that we're looking at. So if in the area there was 1,000 people, it would just give the amount for the 1,000 people. But if there was 10,000 people, it would divide it by 10 so as to give a figure for per 1,000 patients on the list. So as you can see, that is now what's registering on this axis here, items for semaglutide per 1,000 patients on the list. So now we have a different range of different areas that are at the top. So now at the top is North Lincolnshire, which is Scunthorpe and surrounding areas. The next one is North East Lincolnshire, which is Grimsby and the surrounding areas. And we then get Blackpool, Wirral, North Yorkshire, Tameside. And you'll probably notice that these are probably areas more in the north. They may be industrial towns that maybe have a higher level of deprivation and may therefore have more people that may need treating for type 2 diabetes. Down on the opposite end, we have Berkshire, Midwest Essex, Surrey Heartlands, Brighton and Hove, places like Brighton that may have a young population, especially those that go to university in some of these areas. So even though we have taken into account per population, we might not necessarily be taking into account all the different reasons why there's a difference. Also on this data, we have the time series, and this is the graph that shows us how semaglutide has been increasing. And as you can see, when it was first on the market back in 2018, you can probably see one of the first areas to use it was Blackpool were straight off and using it first. But the two that have taken over being at the top, North Lincolnshire and North East Lincolnshire, had we seen before. However, this is just semaglutide, and this is just one of the agents within the group. And as I said, semaglutide is the most recent in this group. The first agent in this group, exenatide, we can have a look for the data for this agent. And here we will see I was going to say, spoiler alert, I've already seen this data. Exenatide, this is the one that was twice daily. It was the original agent. Although it's been out the longest, so we do actually have the longest sort of safety data, the newer agents that are coming on the market are showing to have greater benefits in the long term for people with type 2 diabetes. So as you can see, there's been a move away from using this agent in preference for the newer agents on the market that have got more evidence, especially for type 2 diabetes complications such as cardiovascular issues. So if we move on, so that I don't have to wait for it, I've already been on. So on here, I filled it in with all of the different agents that are on the available on the NHS, and run this again via total list size so that we can actually have a look and see. So obviously we were there, North Lincolnshire and North East Lincolnshire were previously the top. Let's see if they are in the overall. Let's have a look. Overall, yep, North Lincolnshire is still there as the top, and North East Lincolnshire as well. And then we've got the Wirral up there as well, and Blackpool. So how much are these drugs actually costing us? This is showing the actual items and how the items have moved, but how much is this actually costing us on the NHS? If you scroll down, here we have, and they actually list the different items. So at the moment, we're currently spending £22 million a month on these agents for the whole of England. And so over the last 12 months, that has been £231 million for the whole of England for treating type 2 diabetes with these agents. And remember, for the data for this, for the Ozempic brand on the NHS, is purely for treatment of type 2 diabetes. This is not data from the private sector of those people that have been paying privately to get this on the NHS, and it's also not used on the NHS in this data for weight loss, although I will go on to how that's being done for the future. But as you can see with this trajectory going upwards, when you think, so January 22, we were sort of looking at about sort of, 7, we're getting up and going up to 10. So there's a good possibility this 231,000 could be getting on for £400 million in this coming year, maybe then going up to £500 million a year going forward, because we do still have quite a long time until these drugs come off patent and become cheaper for the NHS. Even the exenatide, it may be coming off patent soon, but we won't really see a changeover for people going back to use that one due to sort of the dosing schedule not being as good and it not having the same efficacy. So how does this compare to the whole of diabetes? So I've run the same data again for the whole of the diabetes drugs. And if you look down here, we're getting on to over £800 million a year being sent on diabetes medication. It is one of the biggest cost pressures on the NHS. Firstly, from this new agent, but also due to the cost of blood glucose sensors. And I did talk about this in my previous video on the top 10 drugs in the NHS. I covered the top 10 volume, the top 10 cost, and the top 10 up and coming costs. So I will leave a link below for you to go back and have a look at that previous video. And you may find some other drugs that you may want me to have a look at this data in more detail for the future. I'll finish off this section and move on to how we're now going to be seeing the semaglutide being used for weight loss on the NHS. In this last section, I'm going to talk about the use of semaglutide for managing overweight and obesity and the new guidance that is out for use on the NHS. NICE produced these guidelines back in March 2023. NICE is the National Institute of Health and Care Excellence, and they produce guidance for the whole of the NHS in the hope that it will ensure everybody gets similar availability to different medications across the country. So they have recommended that semaglutide is an option for weight management and weight loss and weight maintenance. But it has to be alongside a reduced calorie diet and increased physical activity. And it can only be used by a specialist weight management service that provides multidisciplinary management of overweight or obesity. Now, these services are usually known as Tier 3 and Tier 4 services. And these are usually run in a local area with contacts with the secondary care hospital consultants, dietitians, physiotherapists, psychologists, and a whole team to help a person really find out the barriers that they've got with losing weight and working out a plan to work forward in analysing their diet and their exercise and coming up with a plan. So these services will be able to be providing Wegovy for these patients. So that they have set some some sensible options of the fact that the BMI must be of at least 35, so people must be into the obese category, and maybe even lower if they've got other different conditions, are part of an ethnic group that are at higher risk of complications from obesity. Also, when people are using this service, they have to remain under this service, remain having the reviews under this service, continually have those talks with the dietitians and altering their diet and lifestyle in line with ensuring their calorie intake is correct, and they're also getting all the nutrients, even if they do suffer with side effects of nausea and reduced eating, that they keep the nutrition up. And with that monitoring, they need to ensure that they do lose weight with this to be able to continue taking it. So there will be a weigh-in at sort of 6 months to check whether somebody's actually lost 5% of their initial weight, to check that they are compliant with both taking the medicine and with the lifestyle changes that need to go alongside this. So one of the reasons why this has to be done by a tier 3 or tier 4 service is that this medicine isn't going to be prescribed on what's known as an FP10 prescription, the prescription that a GP practice can give out, because the price that the Wegovy is providing the NHS, they're using a contract where they supply it directly from the tier 3 and tier 4 services at an approved price to the NHS, unlike the semaglutide, the Ozempic, that's on NHS prescriptions and is charged to the NHS through the normal routes. The Wegovy products also go into 2 strengths that are actually higher than for the licensed dose for treating type 2 diabetes, and that's usually because the higher doses are needed for providing the weight loss rather than just controlling the type 2 diabetes. I hope that you found this video interesting, and if you'd like to see more videos like this, please like and subscribe. I will leave links to my previous videos so that you can go back and look at them. Please comment below with any questions you have and any ideas that you would like me to talk about in future videos.